Would you want to know if cancer is in your future? It's a question most people think about and understandably a tough one to answer. But as a precision medicine and longevity physician, I really believe strongly that knowledge and wisdom can save lives and give us remarkable control over our future health trajectory and the emergence of cancer and other diseases. Precision medicine actually looks for diseases and disorders of aging, which cancer is one of, at the cellular level to identify and predict disease, and even decades before it manifests and emerges as symptoms. Identified early, cancer is curable in a lot of ways, and disease can often be reversed, so we can extend our health spans to match long lifespans that we're living today. Hello and welcome to Healthy Longevity. I'm Dr. Florence Comite, CEO and founder of the Comite Center for Precision Medicine and Healthy Longevity. I know that today's podcast guest, Dr. Eric Klein, shares my passion for predictive, proactive, and preventative medicine, and I'm very happy to welcome you to the show, Eric. Thanks for joining us.
Thanks for having me.
So Eric Klein, who I just found out is a neighbor here in New York now, is a medical doctor and a distinguished scientist at GRAIL, a biomedical company whose mission is to develop safe and effective cancer screening technologies to detect cancer early, again, before symptoms actually emerge, when it can be cured and ultimately change the trajectory of cancer mortality. Dr. Klein previously served as the Andrew C. Novick Distinguished Professor and Chair of the Glickman Urological and Kidney Institute and Lerner College of Medicine at the Cleveland Clinics, where he was also a member of the Department of Cancer Biology at the Cleveland Clinics Lerner Research Institute, the Tausig Cancer Institute, and the Genitourinary Malignancies Program in the Case Comprehensive Cancer Center. Dr. Klein was a fellow in the Distinguished Careers Institute at Stanford University in 2022 and ultimately joined GRAIL in 2023. Dr. Klein's clinical and research interests focus on prostate cancer with an emphasis on genomics and trials or clinical trials. Most recently, his work has centered on the clinical development of cancer screening tests like GRAIL's Galleri test, which is a first of its kind multi-cancer early detection test, a breakthrough test that we have recommended and used since its inception at the Comite Center. I had actually been waiting for these tests to come along because I was really reluctant to study a person through radiological techniques like PET scan. So having a relatively non-invasive way by just drawing some blood and looking for markers that circulate was a wonderful step in the right direction to predict cancer in the long term, but early in the disease course. That's just a very brief introduction to Dr. Klein's very distinguished career and accomplishments. And I don't know how, Eric, you would fit it all on a business card, but that was pretty incredible. Thank you again for chatting today, and let me ask you to start by telling us more about GRAIL and specifically about the Galleri test.
Yes, so Galleri is a blood-based test that measures the presence of what's called cell-free DNA that is derived from cancer cells. And we've known for a long time that when cancer cells grow and the cells multiply and die, that they release all sorts of biologic substances that can serve as signals to their presence into the bloodstream. And so the basis of this test is next generation sequencing, which is what was used to sequence the human genome. And in the background of all the normal cell-free DNA, our assay can detect if a cancer signal is present.
Excellent. Could you explain a little bit more about GRAIL's methylation platform and what that means to determine and detect methylation patterns to predict cancer origin?
Sure. The way to think about this is in two analogies. One analogy is light switches turning on and off, and the other analogy is fingerprints. So methylation is a normal biologic process where DNA is chemically modified to turn genes on and off. And a liver cell, for example, will use methylation to turn on all the genes that make it a liver cell and turn off all the genes that would make it some other kind of cell. And a kidney cell does the same thing to make it a kidney cell. Cancers exploit this normal biologic process called methylation and use it in a little different way. They use it, and all cancers do this. They use it in a way to turn off the genes that prevent them from growing and turn on the genes that allow them to grow unrestricted. And that's a fundamental biologic process, what we call a hallmark of cancer. And so the fingerprint analogy comes in where the number of light switches or the order of light switches on the wall, if you think of methylation as, let's say, 100 light switches on the wall, in a normal cell is going to be, certain will be on, certain will be off. And in a different cell of a different type, different ones will be on and off. And a different pattern occurs in cancer. And so we can exploit that. And we can see the methylation fingerprint of cancer versus non-cancer in the DNA that's in the bloodstream. And using a machine learning algorithm for both of these processes, if there's a cancer signal present, we can predict with more than 90% accuracy where the cancer comes from, what kind of cancer it is, and that helps an efficient diagnostic workup.
Fascinating. And taking a step back for the moment, I'd really like to learn how you first became interested in this type of research, because you've had a very distinguished career at a number of institutions, and then what led you to follow this particular path in your journey?
Yeah, I've always been interested in biomarkers and did some prior work in my career on prostate cancer biomarkers, and I treated urologic cancer patients my whole career. And I had a relationship with GRAIL's very first chief medical officer from some work with another company. And he came knocking on my door while I was still practicing in 2016 and said, "We have this really interesting technology that I just described, and would you be interested in helping us accrue patients to our clinical trials?" And being intellectually curious and understanding the vast unmet need in cancer screening, I was intrigued, and I said yes. So I helped accrue several thousand patients to the first two big clinical trials that GRAIL did. And along the way, I became a consultant. And then I retired from practice. I did a sabbatical at Stanford, and Stanford is in the city next door to GRAIL's headquarters. And so I started at the company's invitation, started spending more time at GRAIL, and I got to understand everything that was going on there, and very, very excited by the technology. And when the opportunity came and they offered me a job, I said yes.
I'm also a little curious, because we all have a reason we go into the particular field. Was there any trigger that led you to become a urologist and then focus predominantly on prostate cancer?
Yeah, I had a kidney stone when I was in college, and I had surgery for it. And being the nerd that I was, when I got back to school, because that happened over spring break. I missed a whole vacation week because of that. When I got back to school, I went to the bookstore and I bought a urology text and I read it cover to cover. And I got really fascinated by it. So when I went to medical school, I had the option of doing a urology rotation as an elective, which I did. And I really liked the people and I liked the kind of conditions that came along. And I was really attracted to the cancer surgery. That's really what got me interested in treating cancer in general. And so that was the career path that I followed.
Wow. And that's a long training path, because besides training in urology, you had to go on to train in urological cancers. It's kind of fun for me looking back in medical school at Yale. There was no separate urology division. And whenever we studied it, because I did an elective in that as well, they weren't really too inviting of women in the room. And the men were all very uncomfortable at that time. At that time, there wasn't that many women in medical school, so it was kind of unusual to be in there. And now I understand it quite well, and then it was difficult. Since then, Yale had created a urology department, and because I do so much work in men and women, I've really had to immerse myself in urological issues, and having two sons and a father and other reasons, and learned quite a bit. But I remember complaining to the first chair of urology how difficult it was for women to learn urology at Yale, so it's kind of interesting. We work with a fair amount of urologists.
That was probably Bob Weiss was the first chair, I think.
Yes, yeah. Yes, and I knew him
A
from
wonderful
school.
man, and
Very
I'm sure
nice.
he was welcoming and warm to you, yes.
Right. He was wonderful. And I have referred plenty of men there to be tested back in the day when you discovered it and you wanted to get beyond, you wanted to market, to do MRI, because they were one of the first places to offer MRI, like Cornell and like NIH. And it was very hard to get people into these institutions to be tested. Now we take it for granted, but just a few years ago, it was challenging, like a decade ago. It's really changed what we can do for people who do get diagnosed and how we can do that early now. But that's why GRAIL is here, and it's fantastic. I'd love to understand a little bit more about what is the opportunity to see which cancers are most easily noticed and found early on. Is there a difference, for example, between solid cancers and cancers that actually tend to circulate in the blood early on as opposed to later metastasizing? And whether it matters whether it metastasizes lymphatically or in what way. I don't have very much knowledge about how cancers begin to deviate. And I'm particularly curious about prostate cancer because I had a former colleague who was told that he had an underlying urological infection, and he had some pain and he had some symptoms, but his PSA was low, and he ended up having a neuroendocrine prostate cancer, which spread very rapidly and unfortunately led to his early death. So that was of interest to me because I don't think that was anything we ever studied in school.
Yeah, let's talk about the unmet need in cancer screening first. I think that will put everything else in context. We currently screen for 5 cancers. We have high-level data for cervical, breast, colon, lung cancer in smokers and prostate cancer. That screening for those cancers reduces mortality, which is terrific. The challenge is that despite the fact that we screen for those 5 cancers and despite the fact that they reduce mortality, we lose more than 600,000 patients a year due to cancer in the United States. In fact, the standard of care screening tests only detect 14% of all cancers, and more than 80% of people who die of cancer die from cancers that we don't screen for. And so that's the big unmet need, is to develop a broad-based test that can detect these cancers that people die from that we don't have good screening tests for. It would be too inefficient to screen for all of them individually because the false positive rate in someone who got 5 or 6 or 8 or 10 individual screening tests would be very high. It would be approached 50% or greater. And so the advantage of a multi-cancer early detection approach is that the test is calibrated to have a very, very low false positive rate while still detecting a broad array of cancers. So this technology can detect dozens of different kinds of cancers that we don't screen for now. The sensitivity for individual cancers varies both across cancer type and biology. So as I mentioned, the test detects DNA fragments, cell-free DNA in the bloodstream, but not all cells get DNA into the bloodstream. And we know that the ones that do, we know not all cancers secrete DNA into the bloodstream. The ones that do are ones that we know behave aggressively biologically, because the ones that are able to shed cell-free DNA are ones that have high mitotic rates, have high metabolic profiles, have necrosis in the tumor and that sort of thing. So the cancers that are detected by these tests are ones that generally are on the aggressive side and need treatment. And we can say that with really good, solid scientific evidence behind it. In terms of sensitivity for specific cancers, it varies. But for example, I always like to talk about pancreatic and ovarian cancer. Our current screening paradigm, we detect 0% of pancreatic and ovarian cancers before they're symptomatic. In the big trials that we did, we can detect 80% of ovarian and pancreatic cancers and 60% of those at stage 1 and 2. And that's where the real opportunity is, to detect the cancers not only in asymptomatic people, but to detect them before they're metastatic and when they can be treated and cured at a lower burden.
And that's fascinating. And with ovarian and pancreatic cancer and screening, what other cancers would you say, if let's say they run in your family or your best friend, because obviously that's always puts a fear in someone, would be the most likely to be detected early on in the course?
Yeah. So the ones that that the test detects best are head and neck cancer, liver and biliary cancer, colon cancer, ovarian, uterine cancer. The kinds of cancers that it doesn't detect almost at all are really early stage, low grade indolent cancers like prostate cancer. And in fact, you asked how I got interested in GRAIL. When I first had the conversation with the chief medical officer, I had in the back of my mind, gee, this sounds like great technology. Maybe we can replace PSA and screen for prostate cancer better. And it turns out that low-grade prostate cancer doesn't shed any cell-free DNA to speak of. And so this is not a good test for low-grade prostate cancer. The flip side of that is we over-detect too much low-grade prostate cancer with PSA. And so this test will not make that problem worse. Skin cancer is not detected well. Thyroid cancer is not detected well. And the reason is that those cancers don't shed much cell-free DNA. And brain cancers are not detected because the DNA can't pass the blood-brain barrier. But for the major cancers that people die from, the test works very well.
Breast cancer also falls into the category for most as like prostate cancer. They don't, shed early on, most of them.
So early stage, so it's interesting. Again, these are biologic issues. It depends on the kind of breast cancer you're talking about. Early stage hormone receptor positive breast cancer, which is over 90% curable, doesn't shed much cell-free DNA. It's not a very aggressive cancer. On the other hand, triple negative breast cancer, which is often missed on mammography, sheds lots of cell-free DNA, and the test works very well for that more aggressive form.
So that's triple negative, HER's negative as well, or HER's positive?
No, HER negative, triple negative, ER, PR negative, and HER negative. And that's the most lethal form of breast cancer. And the test works very well for that. As I said, the cancers that shed DNA into the bloodstream that can be detected by the test are aggressive and need treatment.
Which makes sense. A couple of things to follow up on that. I was always curious about Gleason scoring with PSA, and we are very careful to do PSAs with percent free. Sometimes we do testing doing K4 and other ways to approach MRI, as I mentioned, as well. And there's always been a debate. I don't know where it stands now, but I remember the scientific papers I read from Mayo claiming that you can't really consider, as you alluded to, low-grade prostate cancer, a Gleason 6 as really an aggressive cancer. So there are a number of men now in my field. I come from the hormone field. I'm an endocrinologist trained in multiple fields of endocrine, from peds to GYN to andrology, and men and women. And it's always a debate we have because we do follow up on the change in PSA. We work with people who actually biopsy and follow. We use hormonal agents to protect people's health, so they don't get diabetes and heart disease, heart attack and stroke, far more widespread than prostate cancer that is deadly, if you will. And I had a lot of run-ins with urologists at the beginning, and then slowly they started changing. I would say this started about 15, 20 years ago in New York when I was transitioning from Yale. And I was told, go ahead, you can treat. But a funny story is one of my patients went to Sloan, could not really describe what we were doing, and he met with a researcher there who was going to report me to the Morbidity and Mortality Committee to discuss this. And I had to present the case, and then he came and we met, and he understood immediately what I was doing, because at the time, they were looking to set up VO2 max tests and exercise, and they were recruiting, I think, someone from Duke, because they figured out that exercise is a good thing as people age in terms of, minimizing disease. And since then, we've been great buddies, and I refer everyone to him so he can grow his panel of people to follow. But I've even had people with Gleason 6, which I don't worry as much about, then show up with a biopsy that contains a Gleason 7. How do you think of it, given your deep expertise as a urologist who focuses in on cancer? Is there anything we should do differently to manage these guys?
Well, PSA has been shown to reduce mortality in the European screening trial. And so I'm a believer in PSA and screening people appropriately. The challenge is that PSA is prostate specific, but it's not prostate cancer specific. And benign prostate enlargement, BPH, is far more common than prostate cancer. So on average, most elevated PSA comes from BPH and not from cancer. A second challenge, as you've alluded to, is that really high-grade Gleason's 8 and 9 prostate cancers and neuroendocrine cancers don't make much PSA. So PSA isn't perfect for a lot of reasons. So the way the field has evolved now is there are new tools to distinguish whether or not an elevated PSA indicates the likelihood of cancer. And you've mentioned one of them. The 4K score is one. There's another one, another blood-based test called ISO-PSA. There are some urine-based tests. And before moving to a decision on biopsy, it's appropriate, I think, to repeat one of those tests, do a reflex test, because they better stratify those who are at risk of cancer. And then, as you mentioned, MRI is a great tool for seeing high-grade cancers and targeting biopsy and so forth. It's really revolutionized what we've done. But even MRI isn't perfect. It misses about 20% of high-grade cancers. So that is the way the field has moved.
Yes, and I work with some great urologists. I'm always very impressed, and monitoring with active surveillance is the way we tend to go. But I worry that I don't want to miss anything, and yet I do want to treat people metabolically so that they don't get diabetes, they don't have a heart attack, because that's far more likely than the fact that we've all heard probably most men and most women, when they die at autopsy, you'd probably find niduses of abnormal cells in the prostate and the breast. So it's a common, probably long, aging phenomenon as well.
So, yeah, no question that it is. So I think that the evidence isn't great. In other words, we don't have long-term mortality trials for testosterone replacement in men with prostates. But if you think about it this way, this is how I think about this problem. Testosterone is at a normal level in the vast majority of men who get prostate cancer. It's not abnormally high. It's not that testosterone causes prostate cancer. It's only in metastatic disease where the testosterone androgen axis is deregulated and testosterone fuels growth. So if you get back to the early stage low-grade prostate cancer, if you have a man who's hypogonadal and who's having symptoms from being hypogonadal, it's safe, in my view, to give him enough testosterone to make him asymptomatic and get his testosterone into the normal range. You're not trying to drive it, into the very high range. And there really isn't any evidence that that has an adverse effect on low-grade prostate cancer or causing high-grade cancer. I think there's a bigger controversy here, which is there an advantage to taking testosterone in someone who's not hypogonadal and who has no symptoms? And I think the evidence for that is weaker. And that's not something that I ever did. That's not anything I did in my practice. Yeah.
Well, that's interesting, because back when I trained with a lot of really distinguished people, Ronald Swerdloff for others, and there is a fair amount of data showing how testosterone really is effective in terms of metabolic disease, because we begin to decline in our 30s, testosterone starts falling in men and women, and it definitely leads to a decrease in muscle. I used to use the fact, as you alluded to, that as men age, their testosterone is actually low. I have yet to meet a person, one exception, but still the free T was quite low, in a man at 70 who was on DHEA, which can contribute to testosterone, and his free T was about 70. So having taken care of infants through every decade of life, most men, if not all, decline with age. There's no question about it. It's just
They
like
do. Yeah,
menopause.
absolutely.
It's andropause.
Yes.
And diseases, permeate and emerge. So we have used it and to our benefit in what, years ago, and still occasionally people will pop up and say testosterone causes prostate cancer. I will point out that testosterone is usually quite low when you get prostate cancer. There's actually some association that's been alluded to in the papers about estrogen, which also increasingly gets aromatized from testosterone as men age. And so those were the arguments I used to use both directly with doctors and with patients. It's testicular cancer I'd be concerned about. That happens at a younger age with young men where their testosterone is generally high. So it's been an interesting conundrum, but I've been up and down with it. So I appreciate your input. That's fantastic, and agree that it's still a work. All of medicine is still a work in progress. But when it comes down to the individual patient, you like to be able to give them something to weigh the risk benefit for each of them. So I find that there is also data that shows a low grade that using a low dose of aspirin. It comes out of Europe, so it's the 100 milligram aspirin for 5 years or more actually reduces the rate of pancreatic cancer, but also prostate cancer, colon cancer, and a couple of other cancers of the midline. So that's something we tend to be in favor of. I think the risk of bleeds from a low dose aspirin is far less than the benefit you can experience with it. But that's fascinating, and I really appreciate it. Who do you find your typical clients or patients are who do GRAIL? Is it just about everyone, or, given the price point may be a challenge, is there, do you have one demographic or another that you can point to?
No, you can't point to any demographic. Really, the common feature of the individuals who do it are people who are concerned about the risk of cancer and want to be screened and who want to know. That's what it's about, and that crosses all demographics.
Okay. I think also you pointed out that the test is fairly sensitive and effective with certain cancers when they're really malignant and they shed quickly. I don't think, in my experience, we have not had any false positives. In fact, we've only had one positives in all the years that we've actually been screening, even though we've diagnosed cancer. The cancers that fall into the less aggressive type, like thyroid and breast, that are hormonally positive. Any false negatives where you find out subsequently, if you follow people beyond the GRAIL test, that they in fact had a cancer and it was missed, and what would be the percentage of that?
Yeah, so it's a challenge because we have not seen patients who have had a negative Galleri test and who are let me say this: healthy patients who have no symptoms. We've not seen patients who have had a negative Galleri test and then are diagnosed with an aggressive cancer in the next week or two. So they might be diagnosed with a cancer 6 or 8 or 10 months later. And what we don't know, and there's no way of knowing for sure, is that a new cancer that really wasn't present when the test was done? Or did the test actually miss that cancer? And as I said or implied earlier, no test like this is going to find every cancer. The cancer that it finds has to shed cell-free DNA into the bloodstream, and there has to be enough to be detectable and distinguishable from the background. So yes, there probably are some false negatives. I think the number is very small, but it's hard to know exactly because when someone gets a negative Galleri test, we don't then recommend that they have a cancer workup. So we don't know what the ground truth is. We don't know if they have cancer. Are there some people who have negative tests and then are diagnosed with cancer within the next year? Yes, there are. But that's also true of every other screening test that we use. So again, back to the example of breast cancer, right? Triple negative breast cancer, the most aggressive kind, is often missed on mammography because its appearance is a little different than other kinds of cancers. And it is the most common breast cancer that is detected in what's called an interval cancer between mammograms. So let's say you have a woman who has a negative mammogram and is diagnosed with a triple negative breast cancer 6 months later. Did the mammogram miss it? Was it there and the mammogram miss it? Did the radiologist miss it? Or is it a new cancer? And we don't have enough follow-up data, since we don't work people up for cancer after a negative test, to know the answer to that.
Yeah, no, that's a very wise answer, and I think maybe we will know in the future, given the data out of AI and objective reading of mammograms, which has shown to be very fascinating. I think we do agree that most cancers are, grow over years, but some of them do not, and the interval cancer that you alluded to, which I've never heard that term. That's an interesting term. I think is helpful. I think weighing risk-benefit for everybody is an important issue. So this brings me to the total body MRIs, which I actually did many of them years ago because they were less invasive. And when I was working with startup companies that preceded GRAIL and didn't come to life, they couldn't scale or it didn't work effectively, there were actually several companies that were quite promising. And if somebody had a borderline test, I would do an MRI, and the yield was kind of low. Nowadays, so many people, because they're targeted by Prenuvo and Ezra, all of which are great techniques, are doing testing and then going on to have additional tests when some glitches show up and there are some issues that can be frightening to a lot of folks. So if you were faced with a family history that was, and this isn't a trick question, I'm genuinely curious because of who you are, what you would think about a friend or a family member who's facing a risk given family history and other indications, would you think that it would be wise to get an MRI to look at the prostate or the pancreas, or would GRAIL suffice given the kind of cancer it is and the kind of concern?
Yeah. It's a challenging question to answer because there haven't been any head-to-head studies. But here's how I think about it. For an MRI or another imaging technique to detect the cancer, it has to be of a certain size and location to be visible. And we don't really know if those are the same sort of cancers that a blood-based test can detect. And we do have some patients who are considered false positives, meaning they have a positive Galleri test and a negative diagnostic workup, and they have a cancer signal origin predicted, let's say, of head and neck cancer. And a few months go by, and the clinician, because of family history or smoking or some other reason, persists in doing the evaluation and reevaluates the patient, and they have a head and neck cancer. And that's probably a cancer that was detected correctly by a blood-based test, but one that was so early that it wasn't evident clinically or by imaging and so forth. And so I think they're fundamentally the kinds of cancers that they find are different. And as I said, you can't, on an MRI, if you see a small kidney tumor, for example, you don't know whether or not that's one that needs to be treated or not. Whereas with the Galleri test, if you find a cancer, as I've mentioned, the data are pretty strong that those need to be treated. Those are biologically aggressive cancers. So, one other thing, I've talked to a lot of radiologists about this. Radiologists don't like whole body imaging. I mean, academic radiologists that I've talked to about it, they don't like it because there are a lot of little ditzels and incidentalomas on there that they have to comment on. And that can lead to unnecessary worry and follow-up exams and that sort of thing. So it's a little bit of a dilemma. Having said that, we looked at one of our big studies was the Pathfinder study, which was using Galleri in 6,600 healthy asymptomatic individuals. Healthy meaning no suspicion of cancer. And a subset of those were cancer survivors. And that's a challenging group that's similar to the very positive family history group. And the reason that that's challenging is that they're at double risk. They're at risk for recurrence of their original cancer, and they're at risk for developing a new cancer, a different second primary. How do you screen for those people when you don't know what cancer they're going to get? A blood-based test makes a lot of sense. And if you look, the group at Hopkins published about 2.5 years ago in the Journal of Clinical Oncology, the group that follows high-risk patients at high risk of pancreatic cancer, so family history, diabetes, cysts in the pancreas, that sort of thing. And they screened everybody with endoscopic ultrasound and MRI, I think, of the pancreas. And they found something really interesting, two things. One is that screen-detected pancreatic cancer actually has better survival than symptomatically detected pancreatic cancer, which is no surprise. But more importantly, in that trial, you were 7 times more likely to be diagnosed with a non-pancreatic cancer than a pancreatic cancer. So it brings me to an observation that one of my colleagues likes to make, is that if you're unlucky enough to get cancer, you can't pick what cancer you're going to get. So even if you're adherent with colonoscopy and mammography, you're still more likely to be diagnosed with a cancer that you're not screened for. And that's where I think is another big unmet need that tests like Galleri can fill.
Yeah, I think it's a fascinating, recognition of how, in many ways, we're not very advanced. People have to live the life and then hope for the best. In other ways, I think if we can use a risk kind of indicators, we can help people make good decisions about what would be the best way to go about it. But I agree, I use GRAIL in that fashion as well. I will selectively do treatment, diagnostic tests with MRI, but just in the same way that CAT scans, total body CAT scans to me were largely ineffective, except for maybe the heart and the lung and maybe colon, although not my favorite, because not only did it introduce air and pain, but you couldn't biopsy when you looked at the colon. But there's always something to work towards, and I too selectively use what we apply. But we do test everyone with GRAIL. We do believe at this point in time it's been helpful and reassuring to some degree. We have found people who undergo the full body MRIs to find it fascinating, but there have been a few people who have found, for example, meningiomas, and then it weighs on their mind to not turn it into a pun, and they are fearful of what's going on and wonder what to do, and gone to many neurologists and neurosurgeons, even though these can just be present and not have a problem, with it, or a microadenoma. So it's a conundrum, I think, in today's world, and the costs can go either way. I guess one final thing would be great to hear, but is there anything you want to add there? Because I'm in agreement with everything you've pointed out. I think it's progress is fantastic, but we always want more, and I think patients who can benefit because you can uncover something very early and cure it, as opposed to it continuing to cause disease, death, and dying, like ovarian cancer and pancreatic cancer, are certainly life-changing, and sustaining. Are there clinical trials that are currently ongoing in the field that either GRAIL is involved in or you're aware of for prostate cancer and other cancers that will, also lend itself to reliability, reproducibility, and precision?
Yes. GRAIL has committed to almost 400,000 people in clinical trials, 9 clinical trials, most of which are completed and we have published. But there are 3 big ones that I'd like to mention. One is Pathfinder 2, which is a trial in the U.S. of 35,000 individuals, including more than 20% of the population that's in the study qualifies as underrepresented minorities or underserved communities and so forth. And we'll have results from that trial later this year. We have the only ever randomized trial of multi-cancer early detection that was done in the United Kingdom, called NHS Galleri, which randomized 70,000 people to standard of care screening versus 70,000 standard of care plus Galleri. And we're expecting that readout in a year or so. And then we have another trial with CMS, with Medicare, that Medicare is paying for. That's 50,000 individuals in the Medicare population screened once a year for 3 years. And that study is called REACH, and that just got going last year, and that'll be a few years we have that. So all of those trials will continue to expand the knowledge base that we have about these. But what we've seen consistently across all the trials that have been done, and even in the real world, is that the performance of the test is just as we saw in our very first trial. The false positive rate is very low. It's 0.5%, meaning 1 in 200 people who has a Galleri test is a false positive. The positive predictive value of the test, the likelihood that someone who has a positive test actually has cancer, in our studies was in the mid 40%, but there are now 2 reports, one from the Mayo Clinic and one from Dana-Farber, suggesting that the positive predictive value is a lot higher than that, as they both reported over 70%, and some other real-world experiences that are in the middle of there. And our ability to predict, if you have a positive test, what kind of cancer it is better than 90%. So those are all encouraging results.
With the exception of false positives, when something happens, like the individual you spoke of with the head and neck cancer that showed up 6 months later, so could not be found when the GRAIL Galleri test was done, even though it was positive. So in a way, it's a warning sign if you want to choose to look at it that way as well. And
it is, and we actually have, yes, I agree, and we have some data on how to handle that situation. So the dilemma is, you have a positive Galleri test, you have a negative diagnostic evaluation, what do you do? Is that truly a false positive? What we found in a small cohort of patients, about 150 patients, it seems like the ideal thing to do is to repeat the Galleri test, which we offer free of charge. If the repeat test is negative, we have not observed anybody diagnosed with cancer over the ensuing 18 months. If the repeat test is positive, about a third of those patients were diagnosed with cancer within 10 months. So we think that's the way now to identify those people that you still need a high degree of clinical suspicion, as the example I mentioned.
Fascinating. We've actually experienced that, and the GRAIL folks were very helpful in the test that we had seen, and it was easy to get follow-up and ask questions. So I was always grateful for that, because sometimes it isn't always possible, as you and I know as clinical investigators, to get clear-cut answers, or at least guidance and support along the way. So I think doctors and patients can be reassured. I have an interesting question for you that, I'd love to bounce off of you to see your thoughts. I had one quick one that has to do with, are there competitors coming out of left field or coming out, because I've heard of other groups, particularly in Europe, I think, that are looking at alternative ways to pick up early cancer. That was one question. We can start there.
Yeah, there are lots of competitors in the space, actually. So Exact Sciences is working on a multi-cancer early detection test and have said that they're going to have that on the market later this year. Guardant participated in an NCI-sponsored trial called Vanguard and just recently posted their results. And, the good things about that is that both companies have found results that are very consistent with what we have seen. And in the past, when GRAIL was the only big player in the space, there was some whole skepticism about the whole field. But I think that's gone now because you have multiple independent observations there. And there are lots of other companies in Europe and in China and in the US that are looking not only at DNA, but at other cancer signals in the bloodstream. So yeah, there'll be a plethora of options. We still believe that Galleri will be the first FDA-approved test, though. We are the farthest along in clinical development, yeah.
How much does it cost for an individual? I know they can get the test. I don't know if you need a prescription because we prescribe it for our patients, or a person can elect to just do the test on their own. And the cost?
It must be prescribed by a physician. The cost is $949. The cost is $949 for individuals who do not have a physician who knows about Galleri or is unwilling to prescribe it. They can go online to galleri.com and have a virtual appointment scheduled with a physician who will go through their understanding of the test and their risk factors, and if they qualify, order it for them.
Fascinating. Great. I guess a little bit of a far out question I wanted to ask and wrap up this part of it is I had tested people, as I explained before, a Galleri was available and GRAIL had come to fruition, and found abnormal findings in very reliable, reproducible tests. And then I would go on to do MRIs to look, or specifically do diagnostic workups. Without exception, most of them were negative, and I continued to follow individuals. But one of the theories I had at the time, and I don't know how realistic this is cancer in effect, could it be like an infection where cells can be abnormal, but if you have a healthy immune system and you do a lot of things good for yourself, that you can clean it up and get rid of it? Because there's data out of Yale that shows that most cancers are happening with aging and sort of cells that kind of go awry as we age. And I think it applied to breast cancer was one of the trials I read and studies. Is your feeling that that's possible, that we can actually make bad cells, but then our body gets rid of them with good killer T cells and not too many zombie or senescent cells?
Yes, it probably happens every day. There are billions of cell divisions every day, and that's where cancer comes from, is, disordered cell division at the very start. And so, yes, an intact immune system can probably scavenger those and suppress them and so forth, and that probably happens.
I've been afraid to raise that in any meeting or anything, afraid that people would laugh me out of the room.
There's a theory and a body of literature around
Right.
that. There is.
Oh, I have to look for it. I guess I wasn't vigilant enough because I was just thinking on my own. The other thing we are going forward with, because I experienced it 2 or 3 years ago, is therapeutic plasmapheresis, where the notion that if there are reactive cells because you've had infections like COVID or cytomegalic virus and your antibodies are high, Epstein-Barr, any of them, that you can actually clean up the plasma. And there's some data. It's still a growing field, but I've been impressed with some of the outcomes working on it now.
Yeah, I haven't followed the literature on that at all.
It's a good investment of both time and money, where you really want to do it more than once, at least 3 times. When I did it myself, I found that after 3 treatments, my biological age, to the extent you believe in the data, which I do to an extent, reversed by 15 years. I needed more energy. When I stopped sleeping effectively, because I was building an app to be able to deliver this virtually to people, the work we do, it jumped back up again. So sleep is actually paramount. You really want that. It is the most important. So to wrap up, I'd love to hear, I like to ask people I speak to, if somebody stops you or you're sitting next to someone on the plane, as we invariably do, and they find out you're a doctor or they find out what you do for a living, what would be the one most important thing you might mention or you think in life would be most important to share?
Find a way to relieve stress that is constructive and leads to other good things, and get enough sleep for sure, and eat a plant-based diet. Those are the three big things.
I agree with everything but a plant-based diet in some ways, because I've seen plant-based diets really not be effective for a lot of folks. It's just like looking at genetic variants where some people, I just saw one yesterday, can't fast. They don't have the ability, fasting would do nothing, but absolutely stress reduction. We look at, even meditation is a fantastic, if you can learn to meditate, which has always been elusive for me, but I try, it actually turns off genes that lead to increased cortisol and all sorts of issues with increasing cortisol. But that's a great answer. I really appreciate it. Is there anything you want to add to wrap up what we've shared, or, put a period or an exclamation point on it?
Yeah, this is really exciting technology, and there's a huge unmet need here that MSED technology can address. And I think it's really important that all the related fields and constituencies, patients and advocacy groups and academics and industry, get behind this and figure out how to make it work. And we think that we're doing that. But I'm really excited because of that. When I started just to get back to my career trajectory, this is how I've thought about it. As a surgeon, I can help one patient at a time. As an academic that does clinical trials, I can help maybe hundreds or thousands of patients if the clinical trial is positive. With something like screening for cancer like this, the number of people that can be helped is infinite. And that makes me feel very personally powerful, and that's why I have really embraced the field.
Well, welcome to New York. I loved everything you said, and I hope we can continue the relationship. Please feel free to come visit. It was a very interesting relationship. I felt brave enough to ask you some of the questions that have been percolating in my mind, and you've been very informative. I think this is going to be very helpful to so many people, men, women, children, and who need this kind of screen. And I completely agree. The area I suffered the most with when I started my work at Yale to look at predictive and proactive ways to keep people healthy was cancer. And I struggled with it because it's so ubiquitous. And so GRAIL has offered a solution first to market that really made a difference to all of us.
That's good.
All right.
Well, thanks for having me.
Oh, sure. It was fun. And if I had known you were in New York, I would have made sure you knew that you should come visit, get out maybe. But maybe next time, yeah, we can follow up and see if there's any progression.